Good afternoon, everyone, and welcome to the second Local Health Department peer group call for the ASTHO Million Hearts Learning Collaborative. It's just after 2 o'clock now, so we're going to get started. My name is Katie Potestio. I'm an analyst for health promotion and disease prevention at the Association of State and Territorial Health Officials, ASTHO. I wanted to let you know that we are recording today's call, and we will be posting a recording of our speaker's presentation on the ASTHO website following the call, and also sending out the recording and slides and other call materials after the call this afternoon. The topic of our call today is local public health's role in coordinated care teams. There's both an audio and a web portion for this call. If you are not logged into the web portion yet, you can log in by following the registration link that was sent out earlier today from ReadyTalk in your email. And it will, by clicking that registration link, it will bring you right into our meeting room. And as a reminder, please keep your phone on mute unless you are speaking or asking a question to minimize the background noise in the call. And we will have time for some question and answer and discussion after our presentation, but you can feel free to enter questions into the chat box on your screen at any time during this call. So we'll start off with some introductions to hear who is joining us today. So are there any ASTHO folks on the line? Nope. I know Emily is hiking the Appalachian Trail, so she is not available to call in today. All right, so we'll start with, we'll go through our states and we'll do reverse order. So is there anyone, and please state your name and your organization so we can hear from you. Anyone from Vermont on the line? Oklahoma? Ohio? I know we have our speaker, Carrie Kiernan. Anyone else? New York? New Hampshire? Minnesota?
This is Sue Stroshine calling from Anoka County Public Health.
Great. Hi, welcome. And I'm just getting, I see there's a question about the call-in number, so I'm entering that into the chat box now. If you're logged into the web portion but not the phone line yet. What about Maryland?
This is Barbara Levin from Delmarva.
Hi, Barbara.
I'm joining for Sue Myers, who is unable to join us. Catching up here a little bit late.
All right. Illinois.
This is Cheryl Miles. I'm with Illinois Department of Public Health.
Great. Hi, Cheryl.
Hi.
DC. And Alabama. All right. Looks like some people are maybe being a little quiet. We have looks like 10 people logged in on the web and also on the phone. So we hope to hear from more of you during the Q&A and the discussion. And I just want to double check at this time, is everyone on the phone also able to see the slides? If you're not, let me know and I can send you the link directly.
This is Barb Levin, and I'm still trying to get on that.
Oh, okay.
Do you mind just sending it to my email?
Sure. Yep, I'll do that.
And it's 11b@qhs-inc.org.
Yep, I'll send that to you.
Thank you.
So my colleague Tremenda Green from the National Association of County and City Health Officials, NACCHO, is going to be facilitating today's call. She's the Senior Director of Healthy Communities and Chronic Disease at NACCHO. So Tremenda, I will now hand it over to you.
Thank you, Katie. It's a pleasure to be before you all on this very rainy Tuesday. I hope that everyone is staying dry who's on the East Coast. We have an abundance of lovely spring showers upon us today. But for those of you who are experiencing better weather, I'm really happy for you and sad for us. So for today, we welcome you to the local public health agency call of the ASTHO Collaborative. And we are very excited to have as a speaker for today, Ms. Carrie Kernan, who will bring us a message on Million Hearts Initiative Check It, Change It, Control It, Public Health Community Partnership Development. And Ms. Carrie Kernan is the Assistant Director of Community Health at the Summit County Health Department in Ohio. Carrie is the Assistant Director and Chief Nursing Officer for Summit County. Carrie's experience within public health has focused on community health initiatives and program development, clinical operations, and emergency preparedness. Most recently, Carrie has provided oversight in the development of the Summit County Public Health Care Coordination Unit and is assisting with the development of the Adult Protective Services Care Coordination Community Model. Carrie also serves as co-chair of the Summit County Wellness Council and has oversight of the Community Transformation Grant in Summit County. So as your fellow learning collaborative partner for Ohio, Ms. Carrie Kernan.
Thank you, and good to hear everybody is joining on the call. I'm going to start off with just kind of identifying how we approached the Million Hearts Project here in the state of Ohio. The application was submitted through the Ohio Department of Health, and they reached out to us on the local level as we were one of the Community Transformation Grant recipients. And so the focus of the application was to look at the hypertension compliance component specific to African American males. And our partners on the project, Katie, if you want to go to the next slide, just to kind of outline what everybody's been doing. So the Ohio Department of Health was the applicant. They partnered with us at the local level. And our key partner was the Ohio Academy of Family Physicians. KeyPro came in, and they've been helping with the data, health information technology component. And then United Healthcare was also an active partner as it related to an incentive program that they worked with specific to the providers that were recruited for this pilot. So what we did was the Ohio Academy of Family Physicians has a very strong relationship with a lot of the family physician providers that are across the state of Ohio. And they actually recruited, our goal was to recruit 15 providers here specific to Summit County with a number of requirements if somebody wanted to be a part of this pilot. So they had to have an active EMR in place so that they could pull the data so that we could kind of see the change process with our small test of change on a monthly basis, and they're pulling that data monthly. They also had to agree to attend a one-day training that we held the 1st of March. I think that was on a Saturday. And they also had to agree to a visit from local public health where we went out and met with each of the providers to explain what the resources and services were that we could provide from the Summit County Public Health Department. So our goal was 15. We actively recruited 11. 11 provider practices actually came to that training day. So that was kind of the framework of the application and how we got the providers on board to be an active participant within this pilot. So I'm going to step back a little bit and kind of talk to you about our care coordination unit that we developed. It's about 2 years ago that we first initiated the care coordination unit. And it was, I think to the best of my ability or my knowledge, it was a very new concept for local public health, at least in the state of Ohio. And there may be other care coordination concepts at the local public health level, but I think they're probably very unique to their individual communities, much like ours is. And what the care coordination unit is, it's really a one-stop shop for people, the residents of Summit County, to call into our agency for any assistance that they may need for whatever reason. We do all our scheduling for clinic operations. We do our breast and cervical cancer screenings. We do our dental clinic scheduling. We do Help Me Grow referrals. And we also have our adult protective services calls come into that care coordination unit too as well, which has been kind of a side partnership with our Department of Jobs and Family Services. I have 6 staff that answer the phone Monday through Friday, 8 to 4, and they have been trained to answer any kind of call that comes into the agency. So we get everything from scheduling appointments in our clinics to housing, requests for housing, utility assistance, transportation, pharmaceutical assistance, healthcare access, dental health, behavioral health, bed bugs, lice, whatever you can think of, people are calling in for help. I've had a number of people that have said, well, how is this different than your local INR or information referral? And here in Summit County, it's called our 211 system. And we work in tandem with them. We are not taking over their operations, but we've been working in tandem because through our care coordination unit at the local public health level, I can offer a number of things that our information referral 211 system does not. So when somebody calls in, we aren't just focused on the one reason for the call. We know that more than likely they're calling for one thing. They probably need a few more things. They're just calling in that time of crisis. That's really the first and foremost concern at the time of the call. So my outreach specialists ask about 2 to 3 additional questions just to make sure that we can provide as comprehensive as we can the referral and wraparound supports for that individual. The other thing we can offer is that we can advocate on behalf of the client so that as long as the client gives us permission, we can make a call to a physician, a pharmacy, a social service agency, a hospital system, a long-term care facility, whatever that might be. Because many times these folks struggle with, if we give them referral information, there's so many steps to follow, especially if they're having to go through the application process for eligibility with some of our local assistants. The third thing that we do that's different from our INR 211 system is that we actually then will follow up with the caller 2 to 3 days later to make sure that they were successful with any of the referral information that we provided to them. And many times, because we've identified more than one area of need, they may have been successful in making connections with the first referral, but many times they call back or they tell us that they weren't successful with the second or the third because I couldn't get through, I left a message, nobody calls me back, the individual on the phone wasn't very nice, I was confused by what they were asking us. So we can then make sure that we can follow up and make sure that the additional resources that may be needed are followed up so that it's successful for the client. And the fourth thing that we can offer is the resources from our local public health agency, which is a lot of what has been successful with this Million Hearts pilot. So I have public health nurses, I have registered dietitians, I have registered sanitarians, I have licensed social workers, that if the call for resources or assistance warrants, I can actually send a public health nurse out even to make a phone call or make a home visit so that we can provide those wraparound services for some of those individuals that may need a significant level of assistance. So the care coordination unit, we started it about 2 years ago. It has grown exponentially. We didn't, for example, weren't doing adult protective services when we started, but now that's been a mechanism where we can actually provide our wraparound supports from the health district through care coordination with many of those seniors that are over the age of 60 and find that we have concerns with either self-neglect, abuse, or exploitation. I think you can go to the next slide, Katie. So one of the things that we have done is that with these 11 providers, I've personally gone out and met with each of their staff along with one of our staff, a public health specialist, to meet with each individual provider to find out how best we can provide the supports of the health district through this care coordination unit based on the systems or the processes that each of these individual providers are utilizing. So one of the things that we developed, which is on the website, it's the very first, it says the Summit County Public Health Referral Checklist. Each of those providers that are piloting this, specific to those African Americans diagnosed with hypertension, is that we're finding out what other supports could we help that individual as well as that private provider to help that individual become more successful with their compliance toward their hypertension treatment plan. So I'll give you an example. When we went out to one physician practice, He called back after we left the office. Probably we weren't back here half an hour, and he was very concerned about a senior who happened to be over the age of 60. He didn't feel it qualified as a referral to the Adult Protective Services, but was not convinced that the individual was taking her medications as he had prescribed, and really wanted eyes laid on the client, education provided as far as her hypertension, education on her medication, and a blood pressure check done. So I actually sent out one of my public health nurses who, in addition to the things that the physician was asking, was able to kind of do a very brief home assessment and look at what kind of supports this individual had in place to address the concerns that the physician had. Come to find out, she was fine. She knew what her meds were. She knew about her diagnosis. She was taking her meds, and her blood pressure was okay at that visit. And when we called back then and looped back to that physician, he was just in the process of looking at a number of things that he wanted to rule out as he worked to help this individual become compliant with her treatment plan. We had another physician who had a list of about 15 to 20 clients with hypertension that he had not seen that were identified as no-shows, multiple no-shows for appointments. And so we actually went out and knocked on doors to see if we could locate these folks and find out, had they found another source of their health care? Had they moved away? Were they, did they not understand that they needed to follow back up with the physician? And probably about 50 of those folks had transferred to another healthcare provider. The other 50 were very grateful for the contact and got reconnected back to their physician then for continued follow-up care. I think the other success that we just have had recently is through our 2 hospital systems. We have family practice clinics, so they have a high patient volume. They've got lots of staff between their residents, their interns, their nursing staff, and their whole healthcare team. Is that both of our adult hospital systems have now asked us to come in and be a part of their care team, so that while they're working with the therapy folks, the pharmacist, the physician base, maybe they have a visiting nurse that's going out, but they're now beginning to include public health because, as one physician put it, I had no idea that you offered these services and you don't know how much this is needed. We do have a large refugee population here in Summit County, so I think they struggle with some of those folks needing some of those extra supports. So the other tool that we did develop that some of the physicians have been so impressed with, they've actually asked us to develop one that was similar to medication specific for diabetes management, is that we developed a hypertension drug formulary, and we identified every medication we could think of and find that a physician might prescribe as far as a treatment plan for their clients. And what we did was identify across the board then what pharmaceutical assistance could that physician think about if there's a client that really struggles with payment or insurance coverage for their medications for hypertension. So we have local resources, we have state resources, we have staff that know how to do the pharmaceutical assistance program with any number of pharmaceutical companies. So the physicians have been able to leverage that information based on the challenges of their client as far as medication access, so that they can try to be as successful as they can without having it be limiting for the client. Because some clients have told us, I just don't take my meds because they're way too expensive. And so I think the physicians have found this so helpful that then they came back and they said, we know this isn't part of the pilot, but can you do one for diabetes medication too as well, which we've done. So that's the second document that you see on the screen as far as the drug formulary that we developed. The screening tool that we developed is unique to every practice. All the physicians are working to integrate that screening tool in the process of their EMR. So they've given us some great feedback, and so we've had each of the physician practices do small tests of change based on how helpful that screening tool is and how helpful is the information as it comes to us. As we work to work with the client to meet their needs, and then we close the loop and get back with every physician based on every referral that we get, so that physician knows were we successful in making contact, what referrals and resources did we provide to that individual, are they short-term or long-term, so that it becomes a very active partnership between us and the physician practice. It's not just a one-time thing. Anybody within the physician practice can use that referral checklist. It's not the physician only or the nurse practitioner or the medical provider. It can be from the point of time that that client enters that practice and they talk to the receptionist, they're talking to the medical assistant, LPN, RN, the lab person, and the provider. So anybody who touches that client can work with that client to identify needs across the spectrum of that visit. The clients all provide their permission for us to then go back and contact them. So unless we're doing a cold call for like that one physician that wanted us to actually follow up on clients who had not been seen, all the clients know that they're getting a call from somebody at Summit County Public Health to assist them with resources. So I think that's where we've come. Our goal as the pilot ends in June is that I've promised every physician that we won't go away. In fact, we would like to expand once we've built this capacity with these 11 providers, is that we would like to expand this process to then help them address their clients that are concerned with high cholesterol levels. And I've already had physicians ask, when can we start talking about assisting their diabetes clients? The care coordination unit is not just for this pilot. We've had it, like I said, in place for 2 years, so we serve all the residents of Summit County. You don't have to have any financial eligibility to call in. Much of our resources do have some level of financial eligibility, but that's where my staff can help screen individuals based on their financial status, their health insurance coverage, whatever might be in place, to get them connected to the best resource that we may have available here at the local level. And I think that might be it.
I'm sorry about that. Everyone's trying to unmute their phones, I bet. So thank you so much, Carrie, for that wonderful presentation on your innovation in your coordinated care unit at Summit County Public Health. Now we're going to open dialogue for some questions. If you've submitted questions in your chat box, great. If not, now is the time to unmute yourselves and to ask them questions so that Carrie can address them if you have some. Are there any questions so far? Okay. So I have a question of my own for you, Carrie, relative to your work. When you started the process of initiating contact with your provider community and you had that initial first meeting, how did you, other than the granting process, how did you bring them together?
You mean the individuals within the practices themselves?
Yes. How did you invite them to the table and to promote the pilot? So,
and here's where the Ohio Academy of Family Physicians really were key. They did the recruiting. And they made a very interesting package as far as incentives. So the training day was held on March 1st on that Saturday. I had an opportunity to go in and present, so they heard from me just initially as to what the concepts were going to be presented as far as resources from public health. Every provider practice who signed up to be a pilot was given $400 as far as incentive money that they could use any way they wanted as long as it was geared toward working with their hypertension clients to become more compliant. The majority of them were trying to think of very creative ways to use that $400 to incentivize their clients to keep their appointments, take their meds, whatever that might be. And part of getting all kind of, and I think the physicians as well as the medical assistants and nursing staff that attended the training all got free CEUs for the day. So I think from what OAFP tells me, that's always a great carrot to dangle for participation. And so one of the components for the pilot that benefited us was in order to be the pilot, they were required to meet with us. And there have been a few practices that have said, I don't really think the clientele that we serve probably needs your services, because we do have a few practices that probably are not in the lower socioeconomic or economically disadvantaged areas of the community. But I'll tell you, once we went out there, they readily admitted that, oh, you're right, I do have clients, especially when we talk about the senior populations. And many of them had no idea about the intricacies of our adult protective services model and the supports that we wrap around the seniors within our community. So the first connection was really just an email where I had some of my staff just reach out, send an email, and some were ready to meet, come on out the next day. Others we kind of had to work with the Ohio Academy of Family Physicians to help them understand why we needed to come out, what we had to offer. And like I said, some of the practices, I think we met with the physician and the office manager. The majority of them had all of their practices present so that everybody could hear the message that we had to share.
That's really awesome. And a follow-up question about, engaging your stakeholders. How important was it to develop the relationship with multiple stakeholders to get them to the table? It just wasn't the provider community. It was some other partners that helped in the initiative. How important was that role for them?
I think it was key because I think what we've done that has worked historically within Summit County with the health department is that we have very strong relationships with our safety net providers. So our FQHC, our free clinics, we have a nurse-managed clinic through our academic university. And so I've readily admitted to these physician practices that we've never really been able to reach out and make this connection before. I think because we didn't quite know what their needs might be as related to the resources that we had. And on their end, they had no idea the resources that we could offer. So, and I think it's been instrumental, and as I see some of these larger practices have this multidisciplinary team that comes together, they tend to think bigger, broader as far as what's going to be successful for that client interaction and their treatment plan. So it's not just the physician, it's not just the nurse, it's not just the dietitian. Everybody lends to that whole primary care medical home model. And I think that's the thing, now that I think about it, I forgot to mention, one of the requirements for the practices to be in the pilot is that they had to be in the process to becoming certified to become a PCMH, a primary care medical home. So these practices have bought in and understand the concept of a PCMH, and they're beginning to understand how the connection to their local public health can help them be successful with that PCMH, building that PCMH model.
It's really very interesting. And one of my last discussion questions is, it sounds to me like leveraging your health department's additional resources, offering those services to the provider community as wraparound services that they may not have been aware of, was also a significant selling point to getting the practices to the table.
It was, and the one example I can give you, we have a large family practice with one of our adult hospital systems who sees the predominant percentage of our refugee population, and they have a full-time social worker that works with them. And I think she is so busy that when I could offer the supports of the dietitian and the registered nurse and the social worker, that's when the physician said, you have no idea how much we need these services because we can't do this alone. So I think for them to understand, and I think the other example, I had one physician make a referral, and he just wanted a dietitian to connect with the patient over the phone, because despite his best efforts in the practice, he really didn't feel like that he was able to give adequate time as far as the nutrition education. And so I had one of my dietitians call. I think she was on the phone with the client maybe 20 to 30 minutes, and I think the client felt like he was better informed. And then we looped back to the physician, and he's confident that this is going to kind of help that client build that one greater step, or that one more significant step towards success as far as the management of his disease. So, I think that's one of the questions that I get a lot is, well, who's paying for all your time to offer and provide these resources to the community? And this was a significant decision on the part of our health commissioner and the Board of Health back when we looked at building this unit, in that we actually are supporting this unit with some of our general revenue dollars. I do have some of the staff that's supported by some grant dollars, and we get some of our funding from our contract with our Jobs and Family Services for the Adult Protective Services piece. Excuse me, but the majority of our staff and the nursing staff, the social work staff, the sanitarian staff, the registered dietitian staff are all general revenue supported. Now, it's not taken up a tremendous amount of our time. The bulk of the time is actually spent with the client on the phone. But any one of my clerical specialists that are on the phone, based on that conversation with the client, can make a referral to one of those certified, registered, licensed individuals to then either follow up with a phone call or a home visit. So it's all unique. It's all on an individual case-by-case situation, but the community has been very receptive once they have begun to understand all the resources that we're able to offer. We're like the best-kept secret. We don't market ourselves very well, and this has been our efforts to kind of get the message out on what we can provide.
Awesome. One of my other follow-up questions is regarding follow-up with the provider practices. I know that one of the requirements to be a part of the pilot was that they had EMRs. Are you using those EMRs to provide additional feedback to the provider practice that you've actually had a visit with the client, had a follow-up call with the client, and any other progress reporting that you provide to the provider?
And that's a great question, and we haven't yet. The first data dump happened on March 5th, and so they're trying to do the data component on the 5th of every month. And we've talked with the Ohio Academy of Family Physicians. We actually have a meeting with them on Friday, and I think that's where we're going to start to kind of flush out, because we don't really have access to the data. The data comes through Ohio Key Pro, and then they've been sharing that with the Ohio Academy of Family Physicians. And I think that's where then we're going to begin to step in and say, what was the initial data? Are we beginning to see something change? I'll be honest with you, the data has been a huge challenge for our physician practices. And so when I say that each of them have an EMR, you might say, wow, that's great. Well, it's great, yes, that they have an EMR, but every physician tells me that it's not as great as it sounds. It's incredibly challenging because they can get to the data, but what the data is actually telling them can be a varied level of information. So they're struggling with how to pull this data out that can really be helpful data as it relates to the hypertension clients, helpful data as far as the changes that they're making within the system practice and the process. So they're all kind of struggling. And so I think that's where Ohio Key Pro has been in there to try to help them flesh out exactly how can you pull what you need to pull, what is the story you want to tell based on the data that you have. And then so that's why we haven't really been at the forefront of the data, just because it's been initially so challenging. I think over the months now, when they begin to flesh out some of those bugs, we'll have a more active involvement with taking a look at that data and determining what the story is and what kind of changes are we seeing as we progress along by, within every month's time frame.
Okay, thank you, Carrie. Now that you've seen the pilot program from its infancy up until now, are there any key tidbits you want to share that you've had along the way? Because what they say about learning about failures, some of the failures are some of your greatest lessons. So do you have any specific lessons learned that you wanted to share with the rest of the public health agencies on the call who are considering an initiative like this or already have one in place?
That's a good question. And I may struggle a little bit with answering that, in that we approached this as a pilot. We knew that there was going to be small tests of change, and it could be on a daily basis or weekly basis. I think had we tried to approach this without the support of our state partners, Ohio Department of Health, the Key Pro, our health maintenance organization, United Healthcare, and then the Ohio Academy of Family Practice, I'm not sure we would have been as successful at the local level. Because I think, quite honestly, we would have struggled with the carrot that we could offer to these physician practices to even get our foot in the door. And I think that's something we're going to have to consider, because I my goal is that we can expand this beyond these 11 and continue to grow the number of practices that we are partners with. And so how that's going to look may be very different. I don't know that I'm going to have OAFP in my back pocket as we move down the road, and so I think I'm going to be challenged to try to figure out what's going to be the carrot that I can offer these individuals, because I don't have the incentive money. I don't have the ability to do CMEs for the providers or for the office staff. And so I haven't really I haven't gotten there yet. I'm kind of celebrating my successes now. And I think the other lesson learned is to be very open and receptive to the practices. I didn't want to bring my agenda into their environment. I wanted to help them to understand that I was there to meet them on their terms, to figure out how I best can support their practice. Because I know public health, but I don't know the provider practice other than when I see my physician once a year for my health screening. So, I think that was one thing that we had to be really cognizant from the beginning, is just being very respectful of kind of where they were in the process and helping them to gently and kind of sometimes with some of these provider practices pretty slowly really understand what we have to offer. Because I know there was one physician that thought, I think, that we had some hidden agenda coming in, and we had to talk several times, email and over the phone, to help her kind of understand what our goals were in developing the partnership.
Thank you so much, Carrie, for that insight into your programs. Are there any other callers who might have questions? We don't want to monopolize the conversation, so I'm going to open the call up again for our further discussion.
Tremenda, this is Katie. We did have a couple questions come into the chat box. And one of them was, how many public health nurses are you working with, Carrie, and then what is their average caseload?
So I have a total of 35 full-time public health nurse staff. I have 2 that are designated that I can pull at any point in time. Those registered nurses or public health nurses are also actively working within our Adult Protective Services program. So I can pull them at any point in time, and if they need to help somebody that's 35 and not a part of APS, I can do that. And I have the flexibility with my cohort of public health nurses that I can, if I need to, pull them out at any point in time. I would say at this point in time they really don't have a caseload, because much of what the physicians are needing from the public health nurses are kind of a one-time assessment. I do have maybe 1 or 2 clients that the nurses have followed up with 1 or 2 more times, but at that point we've wrapped those services around that individual. We've closed that case, reported back to the physician, and we won't open that back up unless we get another concern or referral from that physician practice.
Okay, thank you. And then we did have another question, and this was from Susan, and if you want to further clarify after I ask the question, feel free. She was wondering, what's the financial support for patients who are not involved in the grant-funded project?
So individuals who may be calling for help that are not the hypertension clients we're helping?
I assume, yes.
Population. So that all comes from our GR support of the care coordination unit. So as I mentioned, any resident from the community can call in, and there's no payment of services. It's a support that we provide from the public health agency, and as I mentioned before, that's funded through our general revenue dollars.
This is Sue. I was the questioner, and I just want to praise you, offer kudos for being able to get that. I think often that's a kind of budgetary support that is not provided. So congratulations.
Thank you. Well, I think we as much as everybody wishes their crystal ball worked every single day, we tried to think about what the impact of the Affordable Care Act was going to be on our community and our residents. And I tend to tell folks that here in Summit County we tend to be resource rich but coordination poor. So we have a lot of things going on, but I think individuals, especially those that really struggle with systems and trying to figure out eligibility and forms and reaching people and getting assistance, that whole coordination of that process we don't do really well. And so I think we were, trying to look into the crystal ball to see what the outcomes of this Affordable Care Act was going to be, and in anticipation tried to plan as we developed this care coordination unit what should be the role of our local public health agency. And one of the key components we look at is the whole access and assurance of services. So it was a lot of dialogue with our health commissioner and our board of health, and they didn't love it initially, but I think as we help them understand kind of as we're going to grow and evolve and what is going to be the role in public health, this was the outcome. And I've had some people say, well, how did you decide what your care coordination unit looked like? I built it based on what I identified as far as needs within the community. So I didn't want to, like I said, replicate services from our information referral 211. I didn't want to replicate or duplicate anything that was already ongoing. I wanted to be another component that can help with that coordination piece. So, my care coordination unit may look very different if the county next to me decides to build one, because it really needs to be, in my opinion, built to meet the needs of your individual communities.
Terry, from ASTHO and NACHO's perspective, we want to thank you so much for your comprehensive presentation today. It was some very valuable lessons learned about your innovative approach to tailoring your coordinated care unit for your local community. So thank you so much for providing us this insight. I'm going to turn the call over back to Katie at ASTHO to give some upcoming announcements and some other information on the Learning Collaborative. So Katie?
Great, thank you, Tremenda. And yeah, thanks again, Carrie, so much for that presentation. I do have one final question. Where can your colleagues on the call find those tools that you discussed? And then, are you willing to share those tools with ASTHO so we can add them to our resource library and show them as models for this type of work?
Absolutely.
Great.
That might be the easiest way so people can go to that one site if they're familiar with it. So I can send that out to you, Katie, and
great.
And you can put it, absolutely.
Yeah, that would be the easiest. I'll connect with you afterwards about that.
Okay. Sounds good.
Great. And thank you so much, Tremenda, for facilitating the question and answer session. And all of you for participating in the call this afternoon. Again, following this call, we will send out an email with the notes and call recording, as well as the tools that Carrie will share with me. And we will add a recording of the presentation to our ASTHO website for those, if you wanted to share them with some of your partners who weren't able to attend today's call. So looking at your screen now, I wanted to just let you know of a few more upcoming peer group calls that we have scheduled. Tomorrow at 1 p.m. is the second community peer group call. The topic is creating a system around chronic disease self-management. The presenter for that call will be Kate Lorig, who's the founder of the Chronic Disease Self-Management Program. And the registration link is on your screen, and it was also included in the most recent announcement that ASTHO sent out last week. And then next Wednesday, April 23rd at 3 o'clock is the second Health IT peer group call. And the topic of this will be using hospital discharge data to improve blood pressure control, and we'll have members from the state teams in Illinois and Maryland to share the work that they're doing. And again, these calls are targeted towards these peer groups, but if you are interested in the topics, you're more than welcome to call in. If you do need me to send the registration links or you have any other questions, you can contact me directly. My contact information is listed on the screen here. All right, so that concludes our call this afternoon. We'll end a little bit early. Thank you again to Carrie and to Tremenda, and I hope that everyone has a wonderful afternoon.
Thank you.
Thank you.
Thank you. Thank you.